So just starting from the very beginning, so Oogonia, they are the primordial germ cells. If you remember your embryology, they migrate from the yolk sac of the wall of the yolk sac of embryo to the genital ridge at about 6th week. They undergo many mitotic divisions, reach a maximum number of 7 million by around 20 weeks of gestation in the fetus, right? But at the time of birth, only about 1 million remain. So 6 million are destroyed from that 20 weeks till birth. Then by puberty, 2000, about 2 lakh remain. And by 30 years of age, only 26,000 oocytes remain. Out of this also, during our life, only 400 oocytes actually ovulate. The others just degenerate and they are known to undergo atresia. Okay. So actually only 400 oocytes will release their egg. So this is how what happens is in from the birth till puberty till ovulation, all these oocytes, the primary oocyte, they are arrested in the diplotin stage of meiosis 1, M1, right? So when ovulation occurs, so when they are released, they undergo maturation. The one which is released will undergo maturation in the form of first meiotic division, which is getting completed, releasing the first polar body. And now what is remaining is the secondary oocyte. यहाँ पे 46 क्रोमोसोम्स थे, 23 इधर चले गए, 23 आ गए, बट दे आर स्टिल डिप्लॉयड, सब डबल हुए हुए हैं ना यहाँ पे. जब whenever we have meiosis, mitosis, initially it undergoes a doubling. Okay, so 23 chromosomes, but double of all of them. Now, after fertilization, the second meiotic division is completed. So all the 23 extra chromosomes get released as the second polar body, and the mature oocyte has 23 chromosomes now. This happens after fertilization. Now, clinically, what is our importance of this? We see it in embryology when we take out oocytes during ovum pickup. So if our oocyte has come out at this stage, okay, the oocyte is only visible under germinal vesicle is visible. The nucleus part is visible like this. So this is an immature oocyte. So ideally, when we are taking it out, we are not supposed to get this, right? So the maturation part of ovulation should have occurred. This is what we call an M2 oocyte, the one which is now arrested in meiosis 2, the secondary oocyte. And it has one polar body lying like this. So not like this, it doesn't get extruded like this. It gets extruded like this inside the zona pellucida. Okay, and this is the oocyte. So this is a mature oocyte and M2 oocyte, and this is what we want to get when we are doing an ovum pickup in IVF. Okay. Plus, the applied knowledge of this fact is that sometimes during this process, such genetic changes can occur. You can have a primordial follicle with two oocytes, a trinucleate with oocyte. The sperms can be headed like this. Okay. So one has to know that a lot of errors, a lot of genetic problems can occur at this stage itself. Okay, so just a few questions in between to keep it lively and interactive. So which of the following increases significantly with increasing age? Trisomy 13, monosomy X, trisomy 21, or all of the above? C. Are you sure it's not all of the above? Okay, somebody is saying to you also, no, monosomies have never been seen to be associated with age, right? And even trisomy 13 is not. So trisomy 21 in that way is particularly what you just think about it also, na? Whenever we are talking about counseling any pregnant woman about risks of associations with advanced age, we are mostly talking about downs only. Okay, so from your practical knowledge also you can think that it is only particularly this disjunction which has been seen with advancing age. So जो हमने oogenesis के टाइम पे देखा कि यहाँ पे ये डिवाइड हो जाना चाहिए था, this should have been left, but with advancing age this disjunction doesn't occur completely and one extra chromosome can sometimes carry. So the trisomy 21 part is related to increasing age. Okay, now this is a very seemingly simple slide, but it is very important. Okay, so ये mentally याद होनी चाहिए so that any patient that comes to you or you see any reports, you should be able to mentally think कि किस level पे problem हो सकती है, and that's how you will investigate further. So the arcuate nucleus of hypothalamus releases GnRH pulsatile in a pulsatile manner, which acts on the anterior pituitary, the gonadotropin releasing cells. Then they release FSH and LH. The follicle stimulating hormone acts on the granulosa cells. The LH acts on the theca cells. So this basal LH stimulates the theca cells to secrete androgen. This androgen then gets transfused to the granulosa cells. Under the effect of FSH, the androgens undergo aromatization. The aromatase enzyme is activated, and which converts androgen to estrogen, right? And during the luteal phase after ovulation, the LH also acts on both these cells to produce progesterone. Now, progesterone has a negative feedback for LH and GnRH. Estrogen has negative feedback on pituitary and hypothalamus for FSH and GnRH. So, when there is adequate estrogen and progesterone, they tell the pituitary that we are enough. You can stop producing your gonadotropins, and that's how the feedback works. So, there is positive feedback here, then there is negative feedback here. So negative feedbacks can occur in multiple levels. GnRH itself has an ultra short negative feedback loop on the hypothalamus. Then LH also acts on by itself. It will act on negative feedback for GnRH, right? And the long loop, the progesterones and the estrogen acting here. Okay, so ultra short, short, and the long loops of negative feedback. Now we all know that there is this two-cell two-gonadotropin theory. We know FSH acts on the granulosa cells. The granulosa cells are these cells surrounding the oocyte. Then there is a basement membrane, and outside it, the cells that have come from the mesenchyme. They are the theca cells, and LH acts on the theca cells for androgens. But after ovulation, the LH can also act on the granulosa cells for production of progesterone. So this is the luteinized granulosa cells also have the LH receptors. That's the only exception. Otherwise, two-cell two-gonadotropin theory is what is the basic. So how does one follicle develop for the purpose of final ovulation? So there are different stages. There is a primordial follicle stage in which there is just this oocyte surrounded by about 10 to 15 granulosa cells. Then comes the primary follicular stage in which they start to secrete some zona pellucida. The number of granulosa cells increases to about 70. Then we become in layers. पहले एक ही cuboidal था, अब ये multiple layers आने लग जाती हैं, and a little bit of getting surrounded by the mesenchymal cells, which are forming, going to become the theca cells, and slight increase in size as well. Then all these are secreting some secretions which appears as a cavity or antrum that we call. And now this kind of follicle is ready to get acted upon by the FSH to start growing by producing estrogen. And this is also the antral stage, the secondary follicular stage, which is now going to be visible on the ultrasound. Till this stage, they are very small and they cannot be seen on the ultrasound. At least now they have become 500 micrometers, so they can now be visible on the ultrasound. Then the tertial, the mature, where as it keeps growing, it gets more and more granulosa cells. The theca cells divide into two types of layers, the theca interna, theca externa. It becomes more vascular, gets more receptors. Then the oocyte gets surrounded by its cumulosophorus, and the cavity starts enlarging. And this is the enlargement that we see on the ultrasound. And this mature follicle may be around 2 centimeters, 20 mm. So this is what we see, right? And then the one which has become dominant, the tertiary follicle, now it will be ready for ovulation. So this is the ultrasound picture of a mature vesicular follicle or the Graafian follicle. And we know this is currently arrested in the diplotin stage of meiosis 1, right? So here it is still arrested. When ovulation occurs, as when it is getting released, it will complete the first meiotic division and release the first polar body, then get arrested in the metaphase of second meiotic division, right? And after releasing this, the rest of the granulosa cells, the luteinized granulosa cells and the theca cells and all, they become the corpus luteum. Okay, and on ultrasound, it is a visible like this. A hemorrhagic kind of appearance is there, and which has peripheral vascularity, right? So this is how it appears. And this we know now is going to be responsible for secretion of hormones to support the pregnancy if it occurs. Now, I'm going to talk about the concept of like we saw that there are so many follicles, but then ultimately not all are growing. One of them is becoming dominant, and the rest are going atresia. So, what governs that? Okay, so there is a concept of recruitment and selection. This part you need not to worry about. Just think about this cyclical recruitment. So every cycle, some of this we say in general, it's about 5 to 15 of these antral follicles. They start to grow under the effect of FSH. They start to grow. Then one gate becomes dominant. How it becomes dominant, what governs it, we'll see. There is a concept of FSH window and threshold. Okay, so one starts to grow, then gives out a lot of estrogen. Then FSH starts to decrease. The others then undergo atresia. The one which has got selected and become dominant will then release its oocyte and lead to ovulation. Okay. Right. So this is another query that comes to mind, that if only one follicle ovulates per cycle, then how is it possible that we do IVF? So we're going to see how we do a controlled ovarian stimulation. Okay. So this is basically the concept of FSH threshold and window. How in a normal cycle only one follicle gets selected and becomes dominant, whereas in IVF we can stimulate multiple of these antral follicles to become dominant, and all of them can become mature, from which we can take out the oocytes. Okay, so basic thing is FSH, window and threshold. Okay, so the different follicles, see, during the luteal follicular transition, पिछले cycle अभी periods आए हैं, the new cycle is now going to start from day one. So during this transition, a cohort of some antral follicles, we don't really know what governs which ones will be chosen, but that's some things you can leave to God. So some amount of follicles, depending upon the patient's ovarian reserve, they will start to grow. Okay, during this phase. So this is called as recruitment. So some of them have been recruited to start growing, to fight with each other for dominance, selection and dominance in the current cycle. Okay. Now so there is a FSH threshold. So when different follicles are growing, so someone has a threshold of 5 nanograms, someone has 10 nanograms, someone has 11 nanograms, but the FSH is rising slowly. We know that as the FSH is rising, the one with the least FSH threshold and requiring that amount of FSH for the least period of time, a narrow window, that one will get selected. ठीक है, वो select हो जाएगा एक बड़ा follicle. Then it will start to secrete a lot of estrogen. जो follicle grow करने लग जाता है under the effect of FSH, we know it's going to start producing estrogen. This estrogen is going to give a negative feedback to the pituitary to stop making more FSH. So FSH is slowly going to fall, right? Such that only the one which has been selected, which has the maximum number of receptors, which has the most blood flow, that FSH is reaching it best, only that one will keep growing. For the others which had a higher threshold, required FSH for a longer time, they lose it. They have lost the bet, क्योंकि उनको ज़्यादा देर FSH चाहिए था, ज़्यादा टाइम के लिए चाहिए था, ज़्यादा लेवल चाहिए था, बट ऑलरेडी एक ने डोमिनेंस जब ले लिया तो FSH फॉल होना शुरू हो गया. ठीक है, सो अदर्स विल अंडरगो atresia. So this is the concept. So what do we do in IVF? What do you think we do in IVF then? We keep giving FSH from outside. So we are not depending on pituitary FSH alone, right? In a natural cycle, the body is depending only on pituitary FSH. Whereas we keep giving a lot of FSH from here itself, so that even those smaller follicles which were, sort of weak, and required more FSH for a longer period of time, even they get pushed, right? So is that clear? This is a very, very important concept, a very basic thing, but very important. So we keep giving extra FSH so that multiple ones keep get selected and go towards dominance, and we are sort of saving them from atresia by giving them more fuel for growth. Plus, this has application in over oral ovulations as well. अगेन क्लोमिफेन सिट्रेट इट्स अ कॉम्पिटिटिव एंटागोनिस्ट. तो अगर एक फॉलिकल सेलेक्ट हुआ, उसने ईस्ट्रोजन बनाना शुरू किया, बट when it has blocked the pituitary receptor, pituitary is thinking that no, I don't have enough estrogen, so it starts to secrete more FSH, more FSH. So some of the one or two other follicles which had a higher threshold, required a longer window, they also get selected, right? Similarly with letrozole, as it's an aromatase inhibitor, so the FSH is acting on the follicles, and again the body is thinking, since estrogen is not getting produced as much, again the pituitary is thinking that I have a lack of estrogen, and it is secreting more FSH. So where initially ovulation was not occurring, now ovulation is going to occur with higher level of gonadotropin. Okay, so this is what I have already said. So within exogenous FSH, this is how we manipulate the FSH threshold and window. So we raise the concentration also, and we give it for a longer period also, right? Otherwise, normally it was going to go up and come down like this, but we raise the level also by giving our FSH externally, and we give it for a longer period, and we raise the bar as well. Okay.